Sure. So the guideline is very extensive, and it is open access and now available for everybody to use in their standard clinical practice. But you are correct. We continue to perform more and more transplants every year, and we also continue to do a lot better at transplanting patients in terms of improvements in overall survival. So we anticipate larger and larger numbers of long-term survivors. So it's really important that all of us are aware of the specific long-term side effects or late effects that they may be at risk for. And every patient has a unique set of predisposing factors and complications post-transplant that put them at risk for those late effects, as well as what they receive for treatment. So there were a number of different updates in this guideline compared to the prior one. It would take a really long time for me to go through all of them, but a few of the things that I updated at the talk at EBMT were the addition of a number of sections to the guideline, including a focus on hematologic complications and how those should be monitored long-term. There were also a number of updates on how surveillance for subsequent malignant neoplasms should be approached, specifically when assessing for the development of complications such as colorectal cancer or squamous cell carcinoma of the head and neck. So I would like the reader to pay particular attention to those. We also substantially updated our sections on cognitive function and quality of life assessments long-term. So we have also come to recognize more and more that what is important to the patient's quality of life as they're living for decades post-transplant really becomes critical. So we provide some recommendations for assessments on quality of life, patient-reported outcomes, caregiver and spousal support, as well as cognitive function post-transplant. So really wanting to make sure that attention is paid to those sections as well. So a lot of what can be optimized during the transplant process to improve long-term outcomes or survivorship is really dependent on the age of the patient, on what their underlying indication for transplant is. And so it's really varied, but I would say over the years we've accomplished things such as using less radiation, specifically in pediatric patients. That's something that we're striving for. And there are a number of different clinical trials trying to decide whether or not we need to use radiation in pediatric or adult patients. Sometimes we still do, though, and the ultimate goal is really to achieve that cure. But then we also need to know that if we can't take away some of those more toxic therapies, that we need to monitor those patients maybe a little bit differently long-term in order to identify long-term side effects early in order to facilitate diagnosis and treatment of those long-term side effects. The advent of gene therapy, I think, will also change our long-term outlook for some patients who are transplanted for non-malignant diseases. And so I think that there's a lot of exciting changes in transplant and cellular therapy approaches that hopefully will decrease the risk of late effects in pediatric and adult patients. More to be seen, but really important that we continue to study this area, and hopefully we'll see improvements over time. Yeah, CAR T therapy, there's definitely a lot of excitement about CAR Ts. There's multiple different ways they're being manufactured, ways they're being used, either as standalone therapy for patients who are high risk or relapsed for hematologic malignancies, or as a bridge to a transplant. I think that our current CAR Ts definitely are not a cure-all for patients, but we are discovering different ways to employ them, different ways to manufacture them, different targets for the CAR T cells themselves. And so this is just, again, a burgeoning area of research that everybody is very excited about. And once again, I want to emphasize, even though it's really exciting and we're hoping that they are less toxic, and we know they're likely less toxic in the acute term compared to transplant, we need to continue to follow for potential side effects long-term in these newer and more exciting therapies as well, especially assessing things like secondary or subsequent hematologic malignancies, et cetera, things that we may not necessarily anticipate. And so again, even though we're coming up with more novel cellular therapies such as CAR T cells and gene therapy, we need to recognize that it's not just seeing how the outcomes are in the first 6 months or the first year, but the outcomes 10 years following the administration of that therapy as well.